Hi and welcome to Optimum TV. Today I'm joined by Greg Mullen, Chief Operating Officer of Ariceum Therapeutics. Everybody's heard of radiotherapy, Greg, where you use beams of radiotherapy to kill cancers. Tell me how radiopharmaceuticals are different from what we might call traditional radiotherapy.
Yeah, so you're right. So obviously you and others have obviously heard about what's often referred to as external beam radiotherapy, where the patient's put in the machine and the beam is fired through the patient to the tumour, and then actually some of it goes back out. And so while they try to aim most of that radiation to the tumour and hopefully kill the tumour, there is some radiation dose that goes to normal tissue as it enters and leaves the body. With radiopharmaceuticals, they tend to be small molecules that have been radiolabeled with a medical radioisotope, which tend to have quite short half-lives, so they only emit radiation over a short period of time, and they are specific for a marker on the cancer. They are injected into the bloodstream, and so they then go and find the tumour, specifically binds that tumour, and then most of the radiation dose is delivered just to the tumour. Anything that doesn't find the tumour is then in the blood and quickly excreted from the body, usually via the kidney and into your urine. So the coined term is sort of molecular radiotherapy, molecular targeted radiotherapy is often like we like to refer to it. So that's how it differs.
So there's a lot of interest in this space. It's very hot, as I said. Is that mainly explained by the fact that this is a highly targeted form of radiotherapy?
Correct. So because it's highly targeted, we can deliver actually sometimes a much higher radiation dose to the tumour than you would with the traditional radiotherapy. But the radiopharmaceuticals that have been approved to date are well tolerated and relatively safe, and in most countries are delivered as a sort of an outpatient treatment. So you, very much like chemotherapy, you go in, you through an IV into your blood, it's 20 mils infused into your blood, you sit there for 3 or 4 hours, and then you can leave again. So it's a very convenient therapy for the patients and a very well tolerated, on the whole, therapy for patients.
Okay. And talking about the approvals we do have so far, we've got a couple, I understand, using a beta emitter, and please talk to us about what type of emission that is, of an isotope called lutetium-177 in prostate cancer, which has got quite a lot of coverage, a lot of excitement, and also in a rarer cancer called neuroendocrine tumours. Tell me about those, but also tell me how the radiopharmaceutical that you're developing and you're hoping to use, or you are using in a trial we're going to come on to talk about, is different.
Yes, so these two products and cancers you've talked about came about because there were specific receptors on those tumours, somatostatin 2 receptor for the neuroendocrine cancer, and prostate-specific membrane antigen, PSMA, for the prostate cancer. And so this allowed us to make small molecules that specifically bind to those receptors, and then we tagged them with this medical radioisotope called lutetium-177. It emits a beta particle. A beta particle is really identical to an electron. Some people might have heard of an electron, and this can travel over 1 to 3 millimeters, so it creates damage over 1 to 3 millimeter range. And so depending on the size of the tumor and where it binds on the tumor, again, it hopefully imparts most of its damage to the tumor, but it can have some side effects where it will go in the other direction and hit normal tissue. And so, but they've been very, very effective therapies, and both in neuroendocrine and in prostate cancer have significantly improved overall survival. So the patients have lived longer, but importantly, it also improves the quality of life for these patients, particularly prostate cancer. And so that's how it differs from the conventional types of therapies. As we know, with chemotherapy, it tends to be quite transient, but can be quite severe side effects from the chemotherapy. We don't see that with radiopharmaceutics on the whole.
Okay. The radiopharmaceutical that you're developing and you are now trialling in glioblastoma, type of brain cancer, is slightly different though. Tell us how it differs from these lutetium-177 based drugs.
Yeah, so this is an Auger therapy. So it's a different type of emission. It's a low energy electron that's emitted from the outer core of the isotope, and it travels a very, very short range. It travels maybe 1/1,000,000th of a millimeter, so less than the diameter of a nucleus. But when it's in that range, it's very, very toxic, and it works by breaking DNA. It causes so much damage to the DNA that the cell, hopefully the cancer cell, can't repair itself, and the cell dies. And Auger therapy has been around for a long time. We've shown that it works. What's been lacking is a way to target that only to cancer cells versus normal tissue. And that's where this molecule called the PARP inhibitor comes in. That's an approved non-radioactive drug that stops cancer cells from repairing its DNA, and it's located on the damaged DNA. So what we've done is we've taken that concept of being able to specifically deliver a small molecule to the DNA of cancer cells, and we've now radio-labeled it with the Auger emitter, so that we carry that Auger isotope directly onto the DNA of cancer, and then we kill the cell by just inducing this what's called double-stranded break. So a lot of DNA damage, and the cancer cell can't repair that, and it dies. So why is it very good in the brain? Is because we want to maximize the amount of radiation to the tumor, but minimize the amount of radiation to normal brain tissue. And so if we can deliver this specifically into glioblastoma cells, we hope to kill those cells, but spare any normal brain tissue.
So I suppose in any kind of cancer treatment, you want to make sure that it spares healthy tissue, but that's doubly, triply important when it comes to the brain.
Correct. And the trial, which we'll go on to in a minute, when these patients, they go for surgery, and the way glioblastoma grows, it doesn't grow in a perfect sort of spherical golf ball. There are unfortunately small tentacles that grow into the normal parts of the brain tissue. So when you go for surgery, often some of these have to be left behind because the surgeon, and for the benefit of the patient, has to take a decision about how much of that tumor it removes versus normal brain tissue. And so sadly, some of that tumor gets left behind, and it's that part of the tumor that we're trying to target with our therapy, so try to kill off the tumor remnants left behind after surgery.
Okay. The trial is at University College Hospital London, obviously leading NHS hospital, and I understand it's in patients with recurrent glioblastoma. That's where the cancer has sadly come back again. Tell me about a little bit more about the patient group and well, you told me a lot about the treatment itself, but what you hope to achieve from this trial.
Yeah, so that's right. These are recurrent patients. So by that, what we mean are these are patients that have already had one round of surgery. They've had chemotherapy. They've probably also had radiotherapy, and then the tumor has grown back. And these patients are then eligible for a second round of surgery to try and remove the bulk of that regrowing tumor. And then as part of the surgical procedure, we insert something called an Omaha reservoir, which is a fancy name for saying at the end of the surgery, we leave a tube behind, a tiny, tiny tube that flows back into where the tumor was, and all the way up to the surface of the head, where there's then a rubber injection port. And then that allows us to deliver our radioactive drug repeatedly. So we hope to give it once a week for 4 to 6 treatments in total. And as I said previously, the idea is that this drug is then specifically targeting, absorbing into any tumor that's been left behind after surgery. And the idea is to try and kill off as much of that as possible and try and improve their overall survival. The survival in these patients is poor. So from when you're newly diagnosed, from when you're diagnosed the first time to when you die, the overall survival is about 18 months. From the point you then reoccur and then die, the overall survival is about 9 months, so less than 9 months. So what we're trying to do is improve the period by the patient survives by killing off any tumour remnants that's left behind after surgery.
Super. And very quickly, when might you have results?
Mid-2025, we hope to be able to show that it's safe and well tolerable in 15 patients or so, and that will also give us what's called the recommended phase 2 dose. So that will then allow us to move into a phase 2 study should it be safe and we see some treatment-related effects.
Greg Mullen of Ariceum Therapeutics, thank you very much indeed.
Thank you. Bye.
Bye-bye. For more Optimum TV episodes, please visit our website, optimumcomms.com, or our YouTube channel at Optimum Comms. Thanks for watching.